Hello, wonderful students. Myself, Dr. Maddineni Srinivas, your dermatology faculty from Bharat. So, whatever may be the source you are following for dermatology, use these videos as a quick summary, quick recap, last minute revision, high yield one liner series just to summarize whatever topic you have discussed and you have seen the videos. So, this video is going to cover lichen planus, Pityriasis rosea, Pityriasis Rubra Pilaris. We can say papillosquamous disorders other than psoriasis. So, let us begin our discussion with lichen planus per se. Lichen planus, I hope all of you do remember that it is a T cell mediated autoimmune disorder which is going to produce basal cell degeneration of the epidermis, and it is associated with a virus which is hepatitis C virus, and it is autoimmune disorder like psoriasis. And there are various types of the lichen planus, out of which you should know the features of the classical lichen planus, which is going to present with the P's, 5 P's as very classically known. Pruritic lesions, which are papules or plaques which are purple in color, which are going to have plain top. So these are all the P's which you need to remember: purple colored polygonal plain topped papules and plaques which are very itchy. Very important description. Classical lichen planus. Hypertrophic lichen planus, where there are going to be thickened plaques present over the skin. Atrophic lichen planus, where there is going to be depression or atrophic changes present. Follicular lichen planus, I hope you remember the hair involvement in lichen planus is associated with scarring alopecia. This is also called as lichen planopilaris. And the mucosal involvement, especially for you, it is important to remember oral lichen planus. It is going to present with lacy white pattern, which is also called as Wickham's stripe. And linear lichen planus, this concept you can remember, it comes from the Keebner's isomorphic phenomenon, where lesions are going to be seen in a linear fashion over the skin. Coming to the clinical features, so we have already seen what are all the 5 P's. Okay, so the involvement is mainly going to be in the flexor surfaces, mainly the wrist, forearms, ankles, and the lower back. And Wickham's stripe can also be seen, very important, not only in the oral mucosa but also in the skin as lacy white lines. Okay, now coming to the Koebner's isomorphic phenomenon. So this you all know, linear development of the similar looking lesions along the lines of the trauma is called as Koebner's phenomenon. There are other conditions also where we can see this psoriasis, vitiligo other than lichen planus. In the oral involvement, I have already told you that there can be lacy white Wickham stripe which can be seen. And remember, the lesions of the lichen planus, they are going to heal with a very bad pigmentation upon resolution. Okay, coming to the hair nail changes, remember scarring alopecia is very classical, and in the nail, remember the most common finding which we are going to see in the nails is going to be thinning, and also we can see longitudinal ridging, and we can see the classical dorsal pterygium, you, I hope you have heard in your ophthalmology also. So there will be a nail plate destruction where the proximal nail fold is going to destroy the nail plate and it will attach itself onto the nail bed. Anonychia, even the complete nail loss can also occur. Coming to the investigation, because it is a clinical diagnosis, mainly the diagnosis is based upon the clinical features. Other than that, we can also do a histopathology to confirm the diagnosis. So we can also do direct immunofluorescence DIF, where there's going to be a deposition of fibrin at the basement membrane zone or a dermoepidermal junction. Because it is associated with hepatitis C virus, screening of hepatitis C can also be done. Coming to the histopathology, hyperkeratosis, that is thickening of the stratum corneum, can be seen, and hypergranulosis, which is wedge-shaped hypergranulosis, is classically seen in lichen planus. And like we have already told, there will be lymphocytic infiltrate in the form of a band at the dermoepidermal junction, which is called as band-like lymphocytic infiltrate. And because of the basal cell degeneration and the band-like lymphocytic infiltrate, the rete ridges are going to appear like sawtooth. And like I have told you, this band cell, band basal cell degeneration, it is also called as liquefaction degeneration. Because of the band-like lymphocytic infiltrate at the dermoepidermal junction, there is going to be degeneration of the stratum basal cells, which is also called as liquefactive degeneration. And remember, in the epidermis, these lymphocytes are going to produce apoptosis of the keratinocytes, and it is called as, they are called as civate bodies, or they are also called as colloid bodies, which are going to be classically seen in lichen planus. Coming to the other changes, so I hope all of you do remember that the melanocytes are present in the stratum basal layer, and the melanocytes, because of the degeneration of the basal cells, they are going to fall into the dermis, and this is going to produce a pigment incontinence, because of which clinically we can see the very bad pigmentation over the skin. And dear students, the other cells which are present in the stratum basal, which start with the alphabet M, do you remember what is the name of those cells? If you remember, please put your answer in the comment section. Okay, so little quiz for all of you. So treatment is going to be mainly with topical corticosteroids. This is the first line treatment asked so many times in the examinations. If the disease is extensive, then we are going to utilize systemic corticosteroids, and because there is itching, we can use antihistamines, and immune modulators can also be used, like for example calcineurin inhibitors. POA therapy can also be utilized for the treatment of lichen planus, and I have made a dedicated video on POA therapy. You can check the video in that icon, and also in the comments or description I will keep the link. So we have to monitor the patients who are having the oral lichen planus very closely, because there is a possibility that it can transform into malignancy. Spontaneous remission is also seen very commonly, but it is the problem is it takes time, 6 months to 2 years. So we have to monitor and we have to give the treatment. So next topic which we are going to discuss is the Pityriasis rosea. So this is also going to have a viral etiology. I hope all of you remember HHV 6 and 7, human herpes virus 6 and 7, and it usually occurs in the adults, and it is a self-limiting condition. 6 to 12 weeks is the time within which it is going to resolve on its own. So classical Pityriasis rosea, I hope you remember this term. Herald patch, which is also called as mother patch, is a lesion which is initially seen, and there is the inverse Pityriasis rosea which is seen in the flexural areas. So clinical features, remember students, Herald patch is a very important term which you need to remember, associated with Pityriasis rosea. Pityriasis itself means scaling, and here the patients are going to have a characteristic collar-like scale, which is called as collarate scale. And the Herald patch initially will be one small lesion. Later there will be very smaller secondary eruptions seen over the body, which are going to follow the Langer's lines, which are the cleavage lines, which are also called as relaxed skin tension lines, which are basically going to follow the orientation of the collagen fibers in the dermis. So this second eruption, it is going to appear like a Christmas tree. So we are going to describe the pattern as Christmas tree pattern. And remember, there is a hanging curtain sign associated with Pityriasis rosea, and usually it is asymptomatic, or there can be mild pruritus, and it is a self-limiting condition. Like I have told you, 6 to 12 weeks is the duration, after which the condition will self-resolve. So there can be, systemic symptoms may be absent, but or the patient may develop some kind of constitution symptom because it is associated with HHV6 and HHV7. So treatment or management usually reassure because it is self-limiting condition. Antihistamines can be given if the patient is complaining of any itching. Topical steroid may be the ones which are going to be required. Other than that, even phototherapy can be used if the disease is very extensive or it is not responding to the usual treatment modalities. Because it is associated with the virus, acyclovir can also be used in the short duration. So next condition is Pityriasis Rubra Pilaris. So remember, it is unknown in origin. So idiopathic we can call it as. So possibility of autoimmunity and also genetic factors is there. The important gene which you have to remember is CARD14 gene. Sometimes it is also triggered by infections or stress. So there are 6 types of Pityriasis rubra pilaris, okay, out of which you have to remember type 1, which is also called as classical, and it is the most common one where the lesions are going to be widespread. So there are other types also, but out of which you have to remember type 6 is associated with HIV or virus or AIDS. So in the clinical features, remember this was recently asked, the patients are going to present with follicular papules, which are going to be rough keratotic papules, which will ultimately produce a follicular plugging. And the skin color is also very important. It is going to become red. More important color which you have to remember is orange red colored erythematous scaly plaques will be present, which will usually coalesce over the time, which is going to produce erythema which is involving almost entire body, leaving behind few areas which are going to appear normal or white in color, which are called as islands of sparing, or this is also called as nape clades. And if you observe the palms and the soles, you can see that the skin will be very thick, and it is called as palmoplantar keratoderma, or it is also called as PRP sandal. And the patients may go into erythroderma, where there is going to be generalized redness and also associated with scaling of the body, which is going to involve more than 90% of the body surface area. The patients can have the pruritus, and the physical disability can occur because of the skin tightness, because of the thickening of the skin. So diagnosis is through clinical examination. Skin biopsy can also be done. So in the skin biopsy, what are the findings which you are going to see? Orthokeratosis and parakeratosis. Both these changes are going to be seen in an alternating fashion in both horizontal and vertical directions, and this is what is referred to as checkerboard pattern. Checkerboard pattern. And follicular hyperkeratosis can be seen where there will be plugging of the hair follicles. And management, so remember the important management is going to be with the retinoids and precisely oral acetretin. Okay, isotretinoin can also be used, but acetretin is the important drug which you have to remember. Methotrexate can also be used. Topically, moisturizers, keratolytic agents can be used because skin thickening is seen. Even poor therapy can also be used. TNF alpha inhibitors are also going to be utilized. Okay, so I hope this video was helpful. If it was helpful, please do hit that like button and also do share this among your near and dear ones, and try to discuss among yourself whatever we have discussed in this video. Lichen planus, Pityriasis rosea, Pityriasis Rubra Pilaris. And if this video was helpful, please definitely do hit that like button and also do subscribe if you are not yet subscribed. And also leave in the comments whatever you feel about these type of videos, whether they are very helpful or whether they are okay type. And you can put any of your suggestions in the comment section if you are having any other topic to be discussed by me related to dermatology. So we'll meet again in the next video, and till then, happy learning. Sarvam Sri Krishna from Sarvejana Sukhino Bhavantu.